What if I told you that right now in the United States, millions of people with Hashimoto's are being failed by the same medical system that diagnosed them? Not because their doctors are careless, but because Hashimoto's and Sjogren syndrome start with the exact same symptoms. Joint pain, brain fog, fatigue so deep it feels like your bones are tired, dry eyes you've blamed on your phone, a dry mouth you've blamed on your medication, and a body that keeps getting worse no matter how well you manage your thyroid. You think it's Hashimoto's. Your doctor thinks it's Hashimoto's. But something else is running underneath. And it's been there for years. The terrifying part is that even top US clinics miss this. Because Sjogren's mimics Hashimoto's so precisely that the average patient in the United States spends 7 to 9 years describing their symptoms before anyone gives them the right answer. 7 to 9 years of being told their labs look fine. Of being told to come back when things get worse. Picture this. You're 43. Your Hashimoto's is managed. Your thyroid levels look optimized. Your doctor is satisfied. But you are not getting better. Your eyes burn every morning. You wake at 2 a.m. unable to swallow because your mouth is bone dry. Your joints ache on days you've done nothing physical. And every time you bring it up, it gets traced back to the thyroid. Then your dentist finds 4 new cavities despite perfect hygiene. Your optometrist says your corneal surface is showing damage. And your joints have started swelling in a pattern that moves around your body like it can't make up its mind. That is not a thyroid problem. That is Sjogren syndrome. And if you have Hashimoto's, you are at documented elevated risk for it right now. Hit subscribe and leave a like. That helps this channel reach more people who need it. The goal at Health Inside is 200,000 subscribers, and every single person who joins moves us closer. I am going to walk you through revealing a different way Sjogren's is driving in your body, and if you want my Sjogren symptom map that connects these signs to your body, type symptom map in the comments and I will drop the link directly. You already know something is wrong. Your body has been telling you for longer than anyone believed you. Number 1. You have Hashimoto's. You already know what it feels like to have your immune system working against you. The fatigue that doesn't lift no matter how much you sleep. The brain fog that makes a simple conversation feel like thinking through wet concrete. The joint pain, the weight that won't budge, the anxiety that seems to come from nowhere. You've learned to manage it. You've adjusted your life around it. And somewhere along the way you probably told yourself, this is just what living with Hashimoto's feels like. But what if some of what you're experiencing right now is not Hashimoto's at all? What if your immune system moved on to a second target and nobody told you? That is exactly what this video is about. Because there is a condition called Sjogren syndrome that specifically and disproportionately targets people who already have Hashimoto's thyroiditis. A major study published in 2025 tracked over 190,000 Hashimoto's patients, and found a statistically significant elevated risk of developing Sjogren's in that population compared to controls. This is not a rare overlap. This is not an unusual coincidence. This is a documented biological pattern happening to Hashimoto's patients across the United States at a rate that demands attention, proactive screening, and awareness. And the overwhelming majority of Hashimoto's patients have never been told any of this. Not by their endocrinologist. Not by their GP. Not by the specialist they saw twice before being told their labs looked fine. Nobody connected the dots. Nobody explained that having one autoimmune condition is not an isolated event. It is a signal. It is your immune system showing you what it's capable of. And when that signal goes unread, the second condition silently accumulates damage for years before anyone catches it. That stops today. By the end of this video you're going to understand exactly what Sjogren syndrome is, why Hashimoto's patients are specifically at risk, what symptoms to look for right now in your own body, what testing needs to happen, and what the consequences are of letting this go undetected. If you have Hashimoto's and this is genuinely the first time you're hearing that Sjogren's is something you need to watch for, type first in the comments right now. Number 2. Sjogren syndrome is a chronic systemic autoimmune disease. The word systemic is important. It doesn't stay in one place. It doesn't confine itself to one organ. It spreads. It evolves. And in its early stages it can look deceptively mild, which is exactly why it goes undetected for so long. At its core, Sjogren's is an autoimmune attack on your exocrine glands, the glands responsible for producing moisture throughout your body. The primary targets are your salivary glands and your lacrimal glands, your tear glands. When your immune system attacks these, it disrupts their ability to produce saliva and tears. This is why the two most recognizable symptoms are dry eyes and dry mouth. But dry eyes and dry mouth are just the beginning. They are the visible tip of a much larger process happening underneath. Sjogren's also attacks moisture-producing tissues throughout the rest of your body. Your skin becomes persistently dry. Your nasal passages dry out. Women experience vaginal dryness that significantly impacts quality of life. Joints become inflamed in a pattern similar to rheumatoid arthritis. The fatigue that comes with Sjogren's is not ordinary tiredness, it is a profound cellular exhaustion that doesn't improve with rest. The brain fog is real and measurable. And the systemic inflammation affects organs far beyond the glands where it started. Sjogren's is estimated to affect approximately 4 million Americans right now, making it one of the most prevalent autoimmune diseases in the country. It predominantly affects women. And it is chronically underdiagnosed because its early symptoms overlap heavily with other conditions, specifically, Hashimoto's thyroiditis. This is the trap Hashimoto's patients fall into over and over. You already have a diagnosis. You already have a framework for explaining your fatigue, your joint pain, your brain fog. When Sjogren's symptoms begin to layer on top of that framework, neither you nor your doctor questions the existing explanation. The dry eyes get treated as a screen time issue. The dry mouth gets blamed on medication. The worsening joint pain gets attributed to a Hashimoto's flare. And Sjogren's keeps advancing while everyone looks the other way. If your Hashimoto's symptoms have felt like they were getting harder to manage and you can't figure out why, type harder in the comments. Number 3. Now let's talk about why this connection exists, because understanding the mechanism is what makes this feel real rather than abstract. Hashimoto's is an autoimmune condition. Your immune system has produced antibodies, specifically thyroid peroxidase and thyroglobulin antibodies, that attack the cells of your thyroid gland. But the deeper issue is not the thyroid itself. The deeper issue is immune dysregulation. When you have Hashimoto's, your immune system has lost what immunologists call self-tolerance. That's your immune system's ability to recognize your own tissue as safe and leave it alone. When that tolerance breaks down, the immune system no longer has reliable brakes. It has demonstrated it's capable of mounting a sustained, destructive attack against its own host. And that pattern does not stay contained to the thyroid. Research confirms that having any autoimmune condition increases your risk of developing additional ones. The immune dysregulation underlying one autoimmune disease is the same dysregulation that opens the door to the next. Your immune system doesn't compartmentalize. Sjogren's and Hashimoto's share significant immunological overlap. Both involve T-cell infiltration of target tissues. Both involve elevated antinuclear antibodies in many patients. Both disproportionately affect women. Both are driven by chronic immune activation that doesn't resolve on its own. A 2025 study using Mendelian randomization methodology, a research approach designed to assess causal relationships, found evidence of a potential causal link between Hashimoto's thyroiditis and Sjogren's syndrome. Not just association. Causal linkage. This means Hashimoto's may not simply coexist with Sjogren's by coincidence. It may actually be contributing to the biological environment that allows Sjogren's to develop. Separately, researchers found that Hashimoto's co-occurred in approximately 27% of Sjogren's patients. Nearly 1 in 3 people already diagnosed with Sjogren's had Hashimoto's too. The overlap is not rare. It is the norm. If you've had Hashimoto's for several years and nobody has ever explained the concept of autoimmune progression to you, type progress in the comments. Number 4. Let's get specific about symptoms. Because when you know what to look for, you'll recognize them in your own experience in a way you probably couldn't before. Start with your eyes. Sjogren's-related dry eye is not occasional dryness from screen time. It's persistent. It's progressive. The eyes feel gritty, like fine sand is trapped under the eyelid. They burn, especially in the morning. They become red and irritated without clear external cause. Light sensitivity increases. Some patients experience excessive tearing as a reflex response to the underlying dryness, counterintuitive but real. If you've been to an eye doctor multiple times for irritation and the explanation has never fully satisfied you, Sjogren's belongs on your list. Your mouth. Sjogren's-related dry mouth is more than feeling thirsty. Saliva production is significantly reduced, and saliva does far more than keep your mouth moist. It protects your teeth from decay, helps break down food, plays a role in taste. When saliva production drops, swallowing dry foods becomes difficult. You may wake at night specifically because your mouth is so dry. You may develop cavities at a rate that surprises your dentist despite good hygiene. Mouth sores become more frequent. A burning sensation on the tongue is common. If any of this sounds familiar, your salivary glands may be under attack right now. Joint pain in Sjogren's follows a pattern distinct from Hashimoto's joint pain. It tends to be migratory, it moves around. One day the pain is in your wrists, the next it's in your knees. Your hands may feel stiff, particularly in the morning. If your joint pain has felt increasingly unpredictable or resistant to what used to manage it, Sjogren's progression is a legitimate explanation. Fatigue. This is the symptom that gets the least attention because it's the hardest to prove. Sjogren's fatigue is not tiredness, it is a systemic exhaustion that sits in the muscles, the bones, and the mind simultaneously. It doesn't respond to caffeine. It doesn't fully resolve with sleep. It waxes and wanes in a way that feels related to inflammation cycles. For Hashimoto's patients already dealing with hypothyroid fatigue, the addition of Sjogren's fatigue creates a burden that is extremely difficult to communicate to anyone who hasn't experienced it. Skin dryness in Sjogren's is more pronounced than typical Hashimoto's related changes. Lips crack and peel persistently. The scalp becomes dry and flaky. Some patients develop a rash across the cheeks and bridge of the nose resembling the butterfly rash seen in lupus. Brain fog in Sjogren's includes difficulty retrieving words mid-sentence, problems with short-term memory, a sense of cognitive slowing, and difficulty concentrating on tasks that used to be easy. For Hashimoto's patients, this overlaps heavily with hypothyroid brain fog, making it nearly impossible to separate one from the other without proper testing. Swollen glands. One of the more distinctive features of Sjogren's is parotid gland swelling, fullness or puffiness in the area just in front of and below the ears. This can come and go. It's caused by immune infiltration of the salivary glands and is a relatively specific finding that points toward Sjogren's rather than Hashimoto's alone. If you're sitting with this list and recognizing 3, 4, 5, or more of those symptoms in yourself, and you've never been tested for Sjogren's, type recognize in the comments. Number 5. Here is the part of this conversation that nobody in a standard US medical appointment will make time to explain to you. What actually happens inside your body when Sjogren's goes undetected and unmanaged for years? Because dry eyes and dry mouth, while disruptive, are not the reason this video is titled the way it is. The reason this could save your life is what happens beyond the glands. The kidneys are a significant target. Renal involvement in Sjogren's includes a condition called interstitial nephritis, where immune cells infiltrate and inflame the kidney tissue itself. It is silent in early stages. And by the time standard kidney function tests start showing abnormalities, significant tissue has already been affected. The lungs are affected in a notable proportion of Sjogren's patients. Lung manifestations include dryness of the airways, chronic cough, and in more serious cases interstitial lung disease, scarring and thickening of lung tissue that progressively impairs breathing. The nervous system is another target. Peripheral neuropathy, nerve damage in the hands and feet, is one of the more common neurological complications. Patients experience numbness, tingling, burning, and pain in the extremities that can be mistaken for diabetic neuropathy or simply attributed to aging. The gastrointestinal system, liver, pancreas, and blood vessels can all be affected as Sjogren's progresses. And then there is the lymphoma risk. A 2024 meta-analysis found an 8.7-fold increased risk of developing lymphoma in Sjogren's patients compared to the general population. That number needs a moment to land. Not 8.7% higher. 8.7 times the baseline risk. The lymphoma most commonly associated with Sjogren's is non-Hodgkin's lymphoma, specifically B-cell subtypes. The same B cells chronically activated by the autoimmune process become the source of malignant transformation, when that activation goes unchecked long enough. Catching Sjogren's early, while it's still primarily glandular, dramatically changes the outlook. Finding it late, after years of silent progression, is a different conversation entirely. If this is the first time you've understood the full scope of what Sjogren's can do undetected, type scope in the comments. And please share this video with every Hashimoto's patient you know. Number 6. Now let's talk about testing. Because awareness without action is just anxiety. You need to know specifically what to ask for. The two antibodies that confirm Sjogren's are SSA and SSB. SSA is also called anti-Ro. SSB is also called anti-La. These are the autoantibodies your immune system produces when it's targeting the proteins found in salivary and tear gland tissue. According to LabCorp data, SSA antibodies are found in approximately 60 to 70% of Sjogren's patients. SSB in approximately 50 to 60%. SSA is the more sensitive marker. It catches a higher proportion of true Sjogren's cases. According to Mayo Clinic Laboratories, a positive SSA or SSB result is highly suggestive of a Sjogren's diagnosis. These are standard tests available through every major reference laboratory in the United States. One important nuance: SSB rarely tests positive when SSA is negative. Research published in Annals of Rheumatic Diseases confirmed that isolated SSB positivity without SSA has low positive predictive value for Sjogren's. The primary marker to push for is SSA. If SSA is positive, SSB adds confirmation. If SSA is negative but you still have strong clinical symptoms, the conversation doesn't end, it continues with other diagnostic tools. Here is the problem you're most likely to encounter. Many providers will not start with SSA and SSB. They'll start with an ANA, antinuclear antibody test. The ANA is a broad screening test. It is not specific to Sjogren's. Johns Hopkins Sjogren Center confirms ANA is positive in the majority of Sjogren's patients, so a positive ANA should prompt further, more specific testing. The challenge is that some providers, constrained by insurance-driven protocols, will see an ANA that isn't dramatically elevated and conclude further testing isn't yet warranted. They'll say come back in a year. They'll frame it as appropriately cautious. It is not appropriately cautious. It is reactive. And reactive medicine, when it comes to autoimmune disease, means you're sitting in a waiting room while damage accumulates. If you have Hashimoto's and dry eyes, dry mouth, and joint pain, you should be requesting SSA and SSB testing directly. Not in a year. Now, you can name the test specifically. You can reference the clinical overlap between Hashimoto's and Sjogren's as your justification. You are not asking for something unusual. You are asking for standard diagnostic testing for a condition you are at documented elevated risk for. If you've ever been told to come back when things get worse before a provider would run further testing, type worse in the comments. Number 7. There is more to the testing picture than antibodies alone. Lip biopsy is considered by many rheumatologists part of the gold standard diagnostic workup for Sjogren's. Minor salivary gland tissue is removed from the inside of the lower lip and examined for lymphocytic infiltration, immune cells clustering inside the gland tissue. A focus score of 1 or higher per 4 square millimeters is a positive result. This is particularly useful in patients who are seronegative, whose SSA and SSB came back negative but who still have significant symptoms. Negative antibodies do not rule out Sjogren's. They lower the probability, but they don't eliminate it. Eye examination by an ophthalmologist is another component. The Schummer test measures how much moisture the eye produces over a set time using a small strip of filter paper under the lower eyelid. Vital dye staining reveals damage to the eye surface caused by chronic dryness. Salivary gland ultrasound has become an increasingly used tool for assessing structural changes Sjogren's causes in the salivary glands. Immune infiltration leads to glandular changes visible on imaging, and the degree of those changes correlates with disease severity. A complete blood count, comprehensive metabolic panel, and inflammatory markers including erythrocyte sedimentation rate and C-reactive protein help paint the picture of how much systemic inflammation is currently active. Elevated inflammatory markers in a Hashimoto's patient with Sjogren's symptoms should accelerate the diagnostic workup, not delay it. For Hashimoto's patients specifically, adding multiple tissue antibody testing shows whether your immune system is also producing antibodies against tissues beyond the thyroid and salivary glands. This kind of comprehensive immune mapping allows for a much clearer understanding of how broad the autoimmune activity has become. Type list in the comments and I'll direct you to the right resource for everything you should be asking to have tested at your next appointment. Number 8. Let's talk about what happens after diagnosis. Getting a positive SSA result or a confirmed Sjogren's diagnosis is not the end of the road. For many patients it is actually a relief. Because now there is a name for what's been happening. Now there is a direction. Standard management of Sjogren's in the United States focuses primarily on symptom relief. Artificial tears for dry eyes. Prescription eye drops such as cyclosporine ophthalmic emulsion to reduce eye surface inflammation. Saliva substitutes and prescription medications that stimulate saliva production such as pilocarpine and cevimeline. NSAIDs for joint pain. Hydroxychloroquine, an antimalarial, is frequently prescribed for its immune-modulating properties. For more severe systemic manifestations, stronger immunosuppressive therapies may be considered. What is equally important, and often not addressed in the standard U.S. rheumatology visit, is what you can do to support immune regulation beyond prescription management. Diet plays a documented role in autoimmune inflammation. When you know which specific tissues your immune system is attacking, and cross-reference that with documented food cross-reactors for those tissues, you have a personalized, evidence-based framework for dietary decisions. This is not food sensitivity testing. This is using your specific antibody profile to make targeted food choices that reduce the likelihood of driving those antibodies higher. The gut plays a central role in immune regulation. Intestinal permeability, the disruption of tight junctions lining the intestinal wall, has been associated with increased systemic immune activation. Addressing gut integrity through targeted nutritional support and restoration of microbial balance is a meaningful component of comprehensive Sjogren's management alongside Hashimoto's. Sleep is immune regulation. Not metaphorically, physiologically. Deep sleep is when cytokine production is regulated and when inflammatory processes active during the day are modulated. Addressing sleep architecture directly, not just sleep duration, is a legitimate therapeutic priority. Stress and the HPA axis are directly connected to immune function. Chronic psychological stress produces cortisol dysregulation that alters the balance of pro-inflammatory and anti-inflammatory immune signaling. For someone with two autoimmune conditions, the immune consequences of chronic stress are measurable, not abstract. If you've been diagnosed with Sjogren's and feel like your management plan is incomplete, type more in the comments. Number 9. There is something about living with two overlapping autoimmune conditions that the clinical literature doesn't fully capture. The diagnostic delay for Sjogren's in the United States is on average 7 to 9 years from symptom onset to confirmed diagnosis. 7 to 9 years. During that time, patients are not simply waiting. They are going to appointments. They are describing their symptoms. They are being told their labs are fine or their condition doesn't yet meet the threshold for intervention. They are spending years in a system that wasn't designed to find what they have. For Hashimoto's patients, that delay is compounded. Because you already have a diagnosis, every new symptom gets filtered through that existing explanation. Dry eyes become a screen time problem. Dry mouth becomes a medication side effect. Joint pain becomes a Hashimoto's flare that just needs more time. The cognitive symptoms get dismissed as anxiety. The fatigue gets attributed to thyroid levels not being perfectly optimized yet. And the real explanation sits undetected. What this means practically is that you cannot rely solely on the US medical system to catch this for you. You have to come to your appointments knowing what to ask for. You have to name the tests by name. You have to describe your symptom cluster specifically, dry eyes, dry mouth, and joint pain together, because those three symptoms together in a Hashimoto's patient have a clinical meaning your provider should recognize as a Sjogren's red flag. You have to advocate for yourself in the way the system currently requires if you want to be seen accurately. This is not the way it should work. Patients with a documented elevated risk for a specific autoimmune condition should be proactively screened, not left to self-identify. But until the standard of care reflects that, you need the information to walk into that appointment prepared. You are not being a difficult patient by asking for SSA and SSB testing. You are being an informed one. You are not overreacting by raising the possibility of Sjogren's with your rheumatologist. You are applying documented evidence about your own elevated risk. And you are not wasting anyone's time by pushing for answers when your symptoms tell you something is wrong. If you've ever felt dismissed by a medical provider when you described your Hashimoto's symptoms, type dismissed in the comments. Number 10. Let's talk about what happens to your daily life when Sjogren's is running alongside Hashimoto's without being addressed. Your oral health deteriorates in a way that feels disconnected from your dental hygiene. You brush. You floss. You use mouthwash. And you still develop cavities, sometimes multiple at once, sometimes in teeth that have never given you problems. Your dentist may attribute this to diet. But the underlying issue is the loss of saliva's protective function. Saliva neutralizes acid, kills bacteria, and coats teeth with protective proteins. When Sjogren's reduces saliva production, all of those protective mechanisms are compromised. No amount of improved brushing will fully address this without addressing the autoimmune process driving it. Your eyes cause problems at work and in daily life that are hard to explain to people who haven't experienced it. Reading becomes uncomfortable after a short period. Screen use is painful. Driving at night is harder because dryness creates a film over the eye that interferes with visual clarity. Contact lens wear becomes impossible for many patients. The constant awareness of your eyes, the burning, the gritty sensation, the need to apply drops every hour, is mentally exhausting in a way that compounds the fatigue you're already managing. Eating changes. When your mouth doesn't produce enough saliva, food that used to be easy becomes a challenge. Bread, crackers, dry meats, anything that requires saliva to move comfortably through the throat becomes something you have to think about. Social eating becomes awkward. Some patients lose weight because eating becomes effortful rather than enjoyable. Your voice changes. Chronic dryness extends to the throat and vocal cords. Your voice becomes hoarse or tired sounding more quickly. Prolonged talking becomes physically uncomfortable in a way that affects your ability to work and communicate. Sleep quality suffers. Nighttime dry mouth, dry eyes on a pillow, joint pain, and immune-mediated disruption of sleep architecture creates a sleep experience that is genuinely restorative for very few hours. You wake feeling like you barely rested. You fall asleep without difficulty but stay in light sleep. And you start the next day already behind on energy, before the Hashimoto's fatigue has even had a chance to accumulate on top of it. All of this is manageable when identified and addressed. None of it has to be your permanent baseline. If your daily life has been significantly impacted by symptoms that align with what we've described and you've never had a clear answer, type daily in the comments. Number 11. Let's address the questions that come up most often when Hashimoto's patients first learn about the Sjogren's connection. First question: can my Hashimoto's antibodies interfere with Sjogren's antibody testing? No. The thyroid antibodies that define Hashimoto's target different proteins than SSA and SSB. These tests measure different things. They do not cross-react. A positive Hashimoto's antibody panel does not produce a false positive on SSA or SSB testing. Second question: what if my SSA and SSB tests come back negative, but I still have all the symptoms? This happens. Research estimates approximately 30 to 40% of people who clinically meet criteria for Sjogren's are seronegative. Their antibodies don't show up on blood testing. Seronegative Sjogren's is real. It is diagnosed. It is managed the same way as seropositive Sjogren's. If your antibody results are negative but your symptoms are strong and your clinical picture fits, a rheumatologist experienced in connective tissue diseases may pursue lip biopsy, salivary gland imaging, and tear production testing. A negative blood test is a data point, not a final answer. Third question: if I get diagnosed with Sjogren's on top of Hashimoto's, is my prognosis worse than someone with Sjogren's alone? Research actually suggests the combination may carry a somewhat milder systemic phenotype. A study examining 100 consecutive Sjogren's patients found those without Hashimoto's co-occurring were more likely to develop certain severe complications including peripheral neuropathy and lymphoma, though the numbers weren't large enough to reach full statistical significance. This doesn't mean you should be unconcerned. It means you should not catastrophize. An early diagnosis with proactive management is a genuinely favorable position regardless of which combination you're dealing with. Fourth question: does treating my Hashimoto's more aggressively help Sjogren's? Thyroid hormone optimization improves symptoms that are thyroid-specific, some fatigue, brain fog, metabolic symptoms. But it does not address the immune dysregulation driving Sjogren's. The two conditions require two separate lines of management. Optimizing thyroid function does not switch off the salivary gland attack. If you've been managing Hashimoto's assuming better thyroid numbers would eventually make all your symptoms better, type numbers in the comments. Number 12. There is a broader point to this video that goes beyond Sjogren's syndrome, and it's the most important thing I can leave you with. Hashimoto's thyroiditis is not a single isolated diagnosis. It is an entry point. Once your immune system has demonstrated the capacity for autoimmune attack, the question is never whether you're at risk for additional autoimmune conditions. The research confirms that you are. The question is whether you and your care team are being proactive enough to find them early. The list of autoimmune conditions that co-occur with Hashimoto's at elevated rates include Sjogren syndrome, rheumatoid arthritis, systemic lupus erythematosus, multiple sclerosis, celiac disease, type 1 diabetes, psoriasis, and inflammatory bowel disease among others. This doesn't mean you will develop all of them. It means your immune system is operating in a dysregulated state that requires ongoing monitoring, not just periodic thyroid panels. Proactive care for a Hashimoto's patient means regular assessment of the broader immune picture, not just TSH and free T4. It means annual review of symptoms that don't fit neatly into the thyroid framework. It means testing when symptoms suggest it, not waiting until symptoms become undeniable. It means building a care team that understands autoimmune biology comprehensively rather than treating each condition as a separate silo. For many Hashimoto's patients in the United States, that level of care requires them to be their own advocates. It requires knowing what tests exist, knowing what symptoms mean, and walking into appointments with specific informed requests rather than general complaints. This video is designed to give you that. You don't need permission to ask for comprehensive care. You don't need to wait until things get worse. You need the information. And now you have it. If this video has given you something concrete to bring to your next appointment, type appointment in the comments. And if you're not already subscribed, subscribe now because this is exactly what we produce here. Not surface-level overviews. Not vague encouragement. Specific, medically accurate, actionable information you can actually use to take better care of yourself. The symptom map is linked right below this video. It walks you through the full symptom overlap between Hashimoto's and Sjogren's, what to document before your appointment, and what questions to ask. I'll see you in the next video.